right, we talked last time about the different vessels in the body and how they differ. We looked at arteries, the different types of arteries. We talked about veins and capillaries and the different types of capillaries and veins we also see in the body, mostly different types of capillaries. Veins are pretty uniform throughout the body, but we did look at venules. So moving on then, we're going to talk a little bit about the physiology of circulation. Now that we've looked at the anatomy of it, now we'll talk about the actual processes of blood flow and circulation and how they are affected by different factors in the body. So when we look at the flow of blood, we're referring to how much blood is leaving the heart and entering the vessels. So if we look at the concept of cardiac output, which is the amount of blood leaving the heart, leaving each ventricle per minute, we can convert that to blood flow as milliliters per minute. So the cardiac output of a healthy male we talked about is 5.25 liters per minute. So we could convert that to milliliters per minute and look at blood flow. So there's a lot of factors that determine a person's cardiac output and how much blood is entering and leaving the vessels. So we're not going to go into a great detail on that. That's more of a nursing focus, but we are going to talk about just the general physiology. So blood pressure is something that we measure in our patients. It's one of the vital signs that is a good indicator of overall health. If blood pressure is increasing, that puts a lot of pressure on the vital organs and can do damage. So we have to really watch elevating blood pressures. And low blood pressures can be damaging as well because you're not having good push of blood into the tissues. We call that perfusion. If the tissues, such as the brain and kidneys, are not well perfused with blood, those cells are going to suffer. They're going to not receive the oxygen and the glucose that they need to survive. So we have to watch for falling blood pressures just as much as we have to watch for high blood pressure. So when we look at a definition for blood pressure, it's the force per unit area on the blood vessel wall. So we typically find an artery closest to the heart to measure blood pressure with. So when we're looking at patients, getting just general blood pressure checks, we typically use the brachial artery in the upper arm to measure their blood pressure and to see if there's any changes occurring. It is important that if we are monitoring a patient's blood pressure, that we use the same arm every time we check. Not that you want to do it multiple times on the same arm in a short period of time, but that if we measure blood pressure, say in the morning, and we're going to measure it again in the evening, and we measured it on the left arm, we want to continue to measure it on the left arm because there are slight differences on either side of the body, or at least there can be, and we might see a drop or a rise in blood pressure that isn't really accurate just because we use two different limbs to measure the blood pressure. So it's important that we be consistent when we're measuring blood pressure. So if you do that for your job, be sure that you indicate which arm you used, or sometimes we can even use a leg or a wrist or an ankle to measure blood pressure. Just be sure that you are consistent on where you took it and on which side. So we need this pressure wave from the heart, the contractions, and the muscular walls of those elastic arteries to generate this wave. The muscular arteries create the blood pressure wave. We need that pressure difference to keep blood moving from the heart into the capillaries. So blood always flows from an area of high pressure to an area of lower pressure. Be sure to always remember that, just like we see with diffusion, high concentration to low concentration, blood flows from areas of high pressure to areas of low pressure. Recall that the arterial circulation is the high pressure side and the venous circulation is the low pressure side, and the capillaries receive those pressure differences. So we have resistance to flow. That's what is going to increase pressure, is the opposition to flow. We call that peripheral resistance. That means it's resistance to blood flow outside of the heart. So it's in the periphery or in the blood vessels outside the heart that cause this resistance. And we can typically see three different important sources of resistance. One would be how thick the blood is. We call that blood viscosity. The thicker the blood, the more resistance to flow we're going to see. Total blood vessel length. Depending on the length of those blood vessels, that's going to determine resistance of flow. So shorter vessels have less resistance to flow than longer vessels. And blood vessel diameter. Obviously, the larger the diameter, the less resistance to flow we're going to see. So factors that remain pretty constant in a typical patient. We're not going to typically see a big difference in blood viscosity in a patient that's coming in, say, with a pneumonia or some other, condition that isn't specifically related to, let's say, blood clotting or too thin of blood from overuse of blood thinners. We should expect to see the blood viscosity to remain pretty much the same. But again, if a person becomes very dehydrated and loses that plasma component to the blood, and they have more formed elements relative to the plasma, then you're going to see thicker blood, you're going to see a higher blood viscosity, and that can affect the resistance. So in those cases, you'd want to give them fluids. So looking at blood vessel length, like I said, the longer the vessel, the greater the resistance encountered. So the longer vessel that we are measuring blood pressure on, we're going to see a higher blood pressure versus shorter vessels. For example, looking at, say, the pulmonary artery, that's not a very long vessel, so we would expect to see lower pressure in the pulmonary artery compared to, for example, the aorta, because the length of the aorta is much longer than the pulmonary artery. Again, blood vessel diameter is the greatest influence on resistance. So looking at the different factors, this is the one you want to highlight, underline, asterisk. That is something that our body controls. We have sympathetic stimulation to the blood vessels, to the tunica media, that will influence blood pressure and the diameter of those vessels. So obviously, the smaller the diameter, the greater the pressure. The larger the diameter, the more open those vessels are, the lower the pressure. So we want to have a nice balance and not have the vessels too wide open and not too vasoconstricted, because that would cause large swings in blood pressure. So again, vasoconstriction would increase your peripheral resistance and increase blood pressure. And that's why people who have narrowing arteries due to cholesterol deposits are going to have higher blood pressure as a result. And your textbook on page 700 really does a nice job talking about atherosclerosis and what the physiology behind that and some of the consequences of having those narrowed vessels. So if we look at where resistance really increases, it's just before the capillary bed in those small diameter arterioles. So again, on page 700 talks about the atherosclerosis, but it's really important to see that where we see the resistance to flow really stepping up is in those arterioles. And we'll look at a diagram of that in just a minute. So what helps to kind of regulate our blood pressure and stimulate blood pressure is every time the ventricles contract, that creates a pressure wave in the muscular arteries. And when that flow is resisted by those small diameter arterioles, we see an increase in pressure as a result of that. So every time the heart contracts, that's when there's highest pressure in the vessel. And then as the heart relaxes, the pressure drops. So in looking at the pressure throughout the circuit, we're going to see it highest in the aorta, where it's closest to that heart contracting, and it will decline throughout till we get back to the right atrium, where that superior and inferior vena cava are returning blood to the heart. So we would see zero pressure. And remember, the venous side, the veins, is where we see lowest pressure in the circuit. So here we can see we have looking at pressure here, we see high pressure. This is just representing contraction of the heart. We see major pressure waves here in the aorta and the arteries. And then we see a drop in pressure when we get down to the level of the capillaries. But we still do see some increased pressure here because we need a push to get that blood out of the vessels into the capillaries. But once we get out of the capillary bed, you'll see that the blood pressure really drops off, because the veins, the venous side of our circulation, is a low pressure side. So that receives the blood, and it needs help getting that blood back to the heart, because it's not a pressure difference that delivers blood back to the heart, but it is pressure differences that deliver blood from the aorta to the arterioles. And notice here too that we see a drop over the arterioles, but we see less of a variation in blood pressure here. So we do see resistance in the arterioles, but the variation in that resistance, there's less of that over that drop in pressure. So looking at systolic pressure then, that's when we talk about blood pressure, we're looking at a typical blood pressure of 120 over 80. That's the top number, and that's the pressure exerted in that vessel when the ventricles are contracting. And ventricular contraction, we learned, is called systole. So systolic pressure is the top number in a blood pressure reading, and it refers to when the ventricles are contracting. So that number should always be higher than the bottom number. Diastole is when the ventricles are relaxing. So diastolic pressure should be the lowest level of pressure in that vessel because the heart is relaxing and there's no pressure wave being generated. And when we subtract the two numbers, if we take a pressure of 120 over 80, for example, 80 is a typical diastolic pressure, the pulse pressure is the difference between those two numbers. So we're looking at a difference of 40 millimeters of mercury. If we take 120 as a systolic pressure and we take 80 as a typical diastolic pressure, difference between them is 40 millimeters of mercury. And that's what we call the pulse pressure. That's the difference that's the pressure wave that's generated by that high pressure systolic wave and the low pressure diastolic period when the ventricles are relaxing. So we see a pulse of 40 millimeters of mercury. So we talked about the veins being the low pressure side of the circuit. So therefore, what helps blood return to the heart from the veins? And there are a couple of important means by which that happens. The first one is the muscular pump, is that we have major veins running through the nearby veins running through the skeletal muscle, and as the muscles contract, as we're walking, for example, that helps return that blood to the heart. Remember that veins have valves, and valves are an important component of this muscular pump because every time the muscle squeezes on the vein, it pushes the blood upward, but the blood can't flow backward again with gravity because of the presence of the valves. Another important factor aiding in this venous return or return of blood in the veins to the heart is the respiratory pump. When we take a deep breath, we are increasing the pressure in the abdominal area and decreasing the pressure in the thoracic area. So we're essentially pushing that blood from the abdominal region up to the thoracic region, which again is closer to the heart. So we see a difference in those veins. The abdominal veins are compressed, thoracic veins expand, and it draws that blood upward. Again, you're creating these pressure changes physically by taking deep breaths. So if you think about patients after surgery, if we want to prevent blood clots in the extremities or even at the site of surgery, we want to keep that blood moving. So having them walk, even standing at the bedside, encourages use of the muscular pump to get that blood back to the heart. And encouraging them to deep breathe using their incentive spirometer is going to help that blood move from the abdominal region up into the thoracic region. So two very important physiological concepts behind some very common post-surgical activities that we ask our patients to do. And then constrictions, venoconstrictions. We do have some constriction of the vein. There is a tunica media there. It's not quite as significant as we see in the arteries, but there is some sympathetic innervation or sympathetic stimulation to the tunica media to allow blood to move toward the heart. And again, remember, the valves work together with the muscular pump to keep that blood moving upward. So here we can see that the muscular pump in action. So blood is flowing into the veins, and as the muscles around those veins contract, it pushes the blood, squeezes it upward, and then the valves close, preventing it from going backward with the force of gravity. So blood pressure is something that is important to homeostasis. It's delivering oxygen and nutrients to the tissues, keeping the tissues supplied with what they need to survive. So to maintain blood pressure not only requires the work of the heart and the blood vessels, but the kidneys also play an important role, and the brain is constantly sensing and monitoring this blood pressure. So it's part of a negative feedback system that is very tightly controlled using long-term blood pressure control as well as short-term blood pressure control. So things that we can look at that influence our blood pressure, important one would be cardiac output. How much blood is leaving the ventricle per minute? Obviously, the more blood that's leaving the heart, the more blood pressure that's going to exert. If there's less blood pressure leaving the heart, then blood pressure is going to fall. So increased cardiac output, increased blood pressure. Peripheral resistance, we talked about that. The more resistance to flow within the vessels, the higher the blood pressure is going to be. And again, that could be due to cholesterol and plaque buildup in the vessels, increasing peripheral resistance, and that would increase blood pressure. And blood volume. The more blood you have in the system, the higher the blood pressure. So if a person is dehydrated due to, say, vomiting and diarrhea over an extended period of days and they do not rehydrate, they would end up with a low blood volume, which would cause blood pressure to drop. The same is true as if you have a patient that is on dialysis because their kidneys are not functioning and they're not making urine, but they're still drinking fluid or maybe getting fluids by IV. They're going to be taking in fluid and have nowhere to go with that fluid if they're not making urine. So blood volume is going to increase and blood pressure is going to increase. So with kidney patients, we're always making sure we're monitoring their blood pressure to be sure that that blood volume is not getting too high and making their heart work too hard in between dialysis visits. Some of the short-term mechanisms for blood pressure control are these baroreceptor reflexes. We find these reflexes in the major arteries near the heart, in the neck, and also in the chest. For example, the internal carotid is a major vessel running up the sides of the neck that carries blood to the brain, and these will detect changes in blood pressure and respond accordingly to make sure we have good blood supply to the brain. The aortic arch as well has pressure receptors that are sensory receptors, part of the nervous system, sending action potentials to the medulla. If pressure changes, pressure drops, we'll see a change in the force of contraction and heart rate to bring that pressure back up. And it's the aortic arch, those baroreceptors, that are going to influence what changes need to be made to correct blood pressure. So again, we see these in the major arteries of the neck and chest, and the carotid sinus is primarily controlling blood pressure to the brain, and the aortic arch affects, systemic blood pressure in general. So we see these changes as a result of these sensory receptors that are specific to detecting pressure. That's where the word baro comes from. They detect pressure changes and send that information to the medulla oblongata, which will then affect the heart rate, the contractility of the heart, and also look at constriction of the blood vessels. So these are short-term mechanisms, which means that if someone has blood pressure over the long term, these receptors eventually become desensitized to chronically high blood pressure, and they're no longer going to be corrective. They're going to just maintain that high blood pressure, and that's going to be the new normal. So these are only good for short-time blood pressure changes. For example, if you're lying down watching TV or lying down in your bed and you quickly sit up or quickly stand, you could feel a little dizzy, and then as the carotid sinus starts, responds to that change in pressure and initiates that reflex and increases the heart rate and causes a little bit of vasoconstriction, then you'll see that dizziness pass. So that's an example of a short-term control. Those with high blood pressure typically need medications and something a little longer acting to get over that new set point that develops when we have long-term high blood pressure. So this is a nice flow chart from your textbook that looks at different factors that can increase blood pressure. Lots of different factors. If you can kind of follow the flow chart here, some things I want to point out is body size. Body size will increase blood vessel length and cause an increase in peripheral resistance that can cause an increase in pressure. So when someone is overweight, typically we see an increase in blood pressure as a result of that. So sometimes simply losing weight can cause a decrease in pressure. But even regardless of how much adipose is contributing to their weight, just looking at a larger person, say, a football player versus someone who's is smaller body size, maybe not 6'2" and 280 pounds of muscle, looking at a just typical 5'6" person who's about 140 pounds, they're going to have less blood vessel length and probably a little lower blood pressure. Dehydration, a high hematocrit, which means we have less plasma, lots of red blood cells. That's going to increase blood viscosity, increasing peripheral resistance, and increasing blood pressure potentially. Different chemicals, the sympathetic nervous system, epinephrine, norepinephrine, those will increase blood pressure. ADH causes the kidneys to hang on to water. That causes the kidneys not to return fluid back to the blood, essentially. So it decreases urine output, ADH does. So that would increase blood volume, and that could potentially increase blood pressure. And angiotensin II is a hormone that acts on the blood vessels, and ADH as well in high amounts can cause vasoconstriction. Stress, exercise, trauma can affect different factors within the blood itself, which can cause an increase in blood pressure. Obviously, if we lose blood from hemorrhaging, that will decrease blood pressure, but then we have baroreceptors that will kick in, and that will act to increase blood pressure. So lots of different factors. It's important when you look at this flow chart to just see the different factors that affect blood pressure. Take a look at each factor and say what would be, if it was acting by itself, how would that affect blood pressure? And we'll probably do a nice activity in class to have you think about how some of these factors affect blood pressure.